Welcome to the Deep Dive, where we crack open complex topics and pull out the most fascinating, digestible insights just for you. Today, we're venturing into a part of your body that you probably never think about until something serious happens. We're talking about the intricate architecture of your forehead and the central midface. Now, you might initially think of facial fractures as purely cosmetic, but as we're about to discover, injuries here aren't just about appearances, they can be incredibly dangerous. Let's unpack this.
Indeed. We're zeroing in on fractures of the frontal sinus, that hollow space, behind your forehead, and what's called the naso-orbitoethmoid, or NOE complex.
The NOE complex.
I think of the NOE as the delicate bony area right between your eyes, sort of where your nose meets your eye sockets. These regions are central to both how you look and, critically, how crucial systems like your brain, eyes, and nose function. Because they're so close to these vital structures, trauma here can lead to devastating complications. Everything from vision problems, even blindness, to serious infections like meningitis and brain abscesses, and yes, permanent facial changes.
Wow, so the stakes are really high.
Incredibly high. And while these fractures are relatively uncommon, occurring in maybe 2% to 15% of all facial fracture patients, the potential consequences are, well, severe.
So who's generally most at risk for these kinds of severe injuries? Is there a typical profile?
Yeah, the data paints a pretty consistent picture. The vast majority, we're talking between 44% and 85%, result from high-impact events like motor vehicle or motorcycle collisions.
Okay, so major trauma.
Exactly. And unfortunately, young males are disproportionately affected, making up something like 66% to 91% of these cases. It's also crucial to understand that an NOE fracture rarely happens in isolation. In fact, up to 60% of patients with an NOE fracture also have other significant non-facial injuries.
Right, so it's often part of a bigger picture of trauma.
Precisely. Our mission today is really to guide you through this complex landscape, from understanding the subtle anatomy to the cutting-edge diagnosis, innovative treatment, and critically, what the long-term journey looks like for these patients.
Okay, so before we can even begin to understand how to fix these injuries, we really need to appreciate the incredible, almost hidden detail of this part of your face. It's not just a block of bone, is it?
Oh, far from it. Let's start with the frontal bone itself. It begins developing very early, even, before birth. But those frontal sinuses, the air-filled cavities within it, they're barely there at birth. They grow significantly after that. They become visible on x-rays around age 6, mostly done developing by 12 to 16, and surprisingly, can even continue to grow and change until you're 40.
40, wow.
Yeah. And what's truly fascinating is that the internal structure of these sinuses, with their unique sort of nooks and crannies, their internal septa, it's described as extremely variable between individuals. No two are quite the same.
So each person's frontal sinus is like a unique internal fingerprint. That makes sense why every injury might present differently.
Exactly. And it's not just an empty space either.
Right.
Imagine a tiny complex highway for mucus. The entire inner surface of the frontal sinus is lined with this delicate skin called respiratory epithelium, which is covered with microscopic hair-like structures called cilia.
Cilia, okay.
These cilia beat at an astonishing 250 cycles per minute.
Wow, 250.
Constantly sweeping a thin blanket of mucus in a spiral path towards a tiny drainage system into your nose. This drainage system is called the nasofrontal outflow tract, or NFOT.
250 beats per minute. That's incredible, like a constant silent cleaning crew working inside your forehead. And you called it an outflow tract. Is it always a clear tube or can it vary quite a bit?
You hit on a crucial point there. While some people do have what's technically called a true duct, a distinct tube for their NFOT, that's actually only about 15% of us.
Only 15%?
Yeah. For most people, it's more like a shallow recess, or perhaps a more convoluted path that still drains into the middle part of the nose. Understanding this variability is absolutely vital because the health and function of this tiny drainage system dictates so much of the treatment plan after an injury. If that drain gets clogged or damaged, well, you're looking at potentially serious problems down the line.
Right, like infections or those mucosales you mentioned?
Exactly, mucosalis, piosales, yes.
And what about the surrounding bones themselves? Are some parts more fragile than others?
Yes, definitely. The frontal bone is shaped sort of like a concave shield, you could say. The thickest and strongest area is the supraorbital rim that's the bony ridge above your eyebrow, extending out towards your temples.
Okay.
But the area right between your eyebrows, called the glabella, along with the front wall and the floor of the sinus, they're surprisingly thin.
Thinner than you'd expect.
Much thinner. This makes them highly susceptible to fractures from a direct impact. And then we also have to consider these delicate structures in the NOE region, like the medial campoid tendon that's a key ligament supporting your eyelids and giving your eyes their shape.
Mm-hmm.
And the lacrimal apparatus, which is your tear drainage system, these are intimately intertwined with the bones of the NOE complex and are very vulnerable to damage during trauma.
Okay, so a lot of critical structures packed into a small, vulnerable area.
Precisely.
So if you or someone you know has suffered a facial trauma, what are the immediate red flags, the signs that suggest something serious might be going on in this complex central region?
Well, the initial signs are often quite visible. Significant bruising around the eyes, doctors call it periorbital ecchymosis.
Right, raccoon eyes.
Kind of, yeah.
Yeah.
And intense pain, obviously. You might also notice a bruise on the white part of the eye. That's subconjunctival hemorrhage. But specifically for an NOE fracture, you look for a noticeable nasal deformity, severe swelling and bruising of the eyelids, and critically, any sign of cerebrospinal fluid leakage, CSF leakage.
CSF leakage. That sounds incredibly serious. How do doctors even begin to confirm that it's actually brain fluid leaking and not just, a runny nose from the injury?
It is extremely serious. And you're right, distinguishing it is key. Fractures that involve the posterior wall of the frontal sinus or that thin bone called the cribriform plate, which acts as a sealing, separating the brain from the nasal cavity, can indeed cause CSF to leak into the nose.
Okay.
To confirm it, doctors can test even a tiny drop of the fluid less than a raindrop, really for its unique chemical signature.
How do they do that?
They look for specific differences in sugar, glucose, and chloride levels compared to your blood serum. Brain fluid has very particular ratios. There's also a definitive protein test, looking for something called beta-2 transferrin, which is essentially like a fingerprint for CSF. If that's present, it's CSF.
That's a clever way to identify it definitively. Beyond those visible signs, how do they assess the full extent of the damage during a physical exam? Feeling around the area.
Right. So to distinguish a simple nasal fracture from a more unstable NOE fracture, doctors perform specific clinical tests. One common technique involves gently placing the thumb and index finger over the inner corner of each eye, the medial canthus,
Okay.
and checking for any abnormal movement of the bones there. If there's mobility, it indicates instability. They also measure the distance between the inner corners of your eyes, called the intercanthal distance.
The width between the eyes.
Exactly. Normally it's within a certain range, but an increased width is a very strong indicator of an NOE fracture. It suggests the bones supporting those delicate structures have been splayed apart.
Makes sense.
And there are other tests too, like the bowstring test and a bimanual examination, which specifically help assess if that crucial medial canthal tendon, the one supporting your eyelids, is still stable or if it's been torn or detached.
Okay, so a hands-on assessment is still really important. And what about imaging? How do they get the full picture of the internal damage?
Today, computed tomography or CT scans are absolutely the gold standard.
Old CT scans, right.
We're talking about incredibly detailed high-resolution 2D and even 3D images taken in very thin slices like 1 or 1.5 millimeters thick.
How super detailed.
Extremely. These scans give surgeons the most comprehensive view of the entire fracture anatomy. They can see exactly where the breaks are, how displaced the fragments are. However, it's worth noting something important. While CT scans are excellent for showing the anatomy of that NFOT drainage system, they're not always perfect at detecting if the outflow is actually blocked, functionally blocked.
So you can see the pipe, but not necessarily if it's clogged?
Exactly. So if there's a strong clinical suspicion of obstruction based on the injury pattern or symptoms, surgeons often need to check it directly during the operation itself.
Got it. So when injuries are this intricate, with all these variables, how do surgeons categorize them? Is there a system to help decide on the best treatment path?
Absolutely. Classification is crucial for guiding treatment, especially for the NOE fractures. They're generally sorted into 3 types, using what's called the Markowitz classification. It essentially describes how shattered the bone is, and specifically, how that affects the medial canthal tendon, that key structure for your eyelids we talked about.
Okay, so what do those types mean in practical terms for treatment?
Well, type I is the least severe. In this case, the medial canthal tendon is still firmly attached to a large single piece of bone. So the repair is relatively straightforward. You just need to put that single piece back in place. Type 2 involves more fragmentation. The bone is broken into more pieces, it's more comminuted, but the tendon is still attached to a recognizable, albeit smaller, bone fragment. Still fixable, but a bit more complex.
More pieces to the puzzle.
Exactly. Then type 3 is the most severe. Here you have severe comminution, meaning the bone supporting the tendon is completely shattered into tiny pieces, and crucially, the medial canthal tendon itself might actually be torn away, avulsed from its bony attachment altogether.
Oof. That sounds much harder to fix.
It is. This kind of injury is much more complex to repair and to restore that normal eye shape and function correctly.
And for the frontal sinus fractures, what are the primary concerns driving classification and treatment there? Is it similar?
For frontal sinus fractures, the main considerations are a bit different. It comes down to which walls are broken, the anterior or front wall, the posterior or back wall, and again, a condition of that crucial nasofrontal outflow tract, the NFOT, the drain. So if only the front wall is fractured, the primary concern is mainly cosmetic, preventing a noticeable dent or deformity in the forehead.
Makes sense.
But if the posterior wall is involved either alone or with the anterior wall, because it's literally the barrier right next to the brain,
Right.
the treatment goal shifts dramatically. The absolute priority becomes avoiding serious neurologic sequelae, things like those devastating infections, meningitis, or brain abscesses.
Okay, brain protection above all.
Absolutely. And then any fracture pattern, regardless of which walls are involved, that compromises the NFOT drainage system.
Yeah.
That has to be treated specifically to prevent those delayed complications, the mucosales or pyosales, those expanding cysts of trapped mucus or pus that can slowly grow and cause damage for years.
So prevention of future problems is a huge driver.
A massive driver, yes.
So let's talk treatment. What does it actually look like for these complex injuries? What are surgeons ultimately trying to achieve?
The absolute primary goals are, number one, to create a safe sinus environment. That means minimizing those dangerous long-term complications we just discussed. And number two, most critically, protecting the brain.
Safety first.
Always. Then, restoring appearance, cosmesis, and function is a major secondary goal. Especially for NOE fractures, this involves rebuilding the eye socket accurately, ensuring the eyelids function properly, and restoring normal tear drainage.
And how do surgeons even gain access to such a delicate area right there in the center of the face without causing more damage or leaving a really visible scar? That seems like a major challenge.
It is a key challenge,
Yeah.
surgical access.
And the preferred method, certainly for frontal bone and sinus fractures, is often what's called the coronal approach.
Coronal approach.
Yeah.
What does that involve?
It involves an incision made across the very top of the head, but hidden well behind the hairline, usually from ear to ear.
Ah, so like a headband incision, but hidden by hair. Exactly. It sounds extensive, but it actually offers the best access to the frontal bone and sinus for complex repairs while producing the most desirable cosmetic results long-term, because the scar is completely hidden in the hair. We generally try to avoid older approaches like gull-wing or spectacle incisions or the open sky approach, as they can unfortunately leave noticeable scars right on the forehead or the bridge of the nose.
That's a clever way to prioritize the aesthetics. Once they're in, what happens to all those broken bone fragments? Do they just remove them if it's badly shattered?
No, not usually, not if they can help it. Meticulous osseous recovery is performed. That means surgeons carefully collect every viable bone fragment, almost like assembling a tiny three-dimensional jigsaw puzzle. Fragments are gently separated from the surrounding tissue, the periosteum, removed, and often numbered and mapped out on a sterile table so they know exactly where each piece goes for later reassembly.
Wow, like numbering puzzle pieces.
Pretty much. And even if fragments are slightly contaminated, say from the sinus cavity, they can often be thoroughly cleaned with copious irrigation, scrubbing, even antiseptic solutions, and then used as free grafts to reconstruct the area.
So salvaging the patient's own bone is key.
Very much so. And this process of removing the fragments is also vital because it gives surgeons a clear, unobstructed view to inspect the posterior wall of the sinus, check for any dural tears, and most importantly, to directly evaluate the status of that critical NFOT drainage system.
Right. And how do they check that all-important NFOT during surgery to make sure it's actually working, not just visible?
Good question. Once they have clear access, the surgeon can often directly visualize the opening of the NFOT. But to confirm its function, its patency, they'll typically place a small, thin catheter, like an 18-gauge angiocatheter, into the duct opening. Then they gently introduce a special liquid, often just sterile saline, or maybe a safe dye, like fluorescein, and watch to see if it flows freely out into the patient's nose.
Ah, like a plumbing test.
Essentially, yes. They specifically avoid certain dyes, like methylene blue, because it can stain everything and disrupt visualization, or Congo red, because it's actually neurotoxic.
Yeah.
So Fluorescein or saline are preferred.
Got it. So, what happens for a truly severe fracture, like a break in that crucial posterior wall of the frontal sinus, the one right near the brain? You mentioned neurosurgery involvement.
Yeah, posterior table fractures are always a major concern because of that proximity to the brain and the dura, the brain's covering. These types of injuries invariably involve damage that could expose the brain or allow infection to track inwards, so they always necessitate immediate consultation with a neurosurgeon, or often joint management, where both the facial trauma surgeon and the neurosurgeon work together during the surgery.
Okay, a team approach.
Definitely. And for the most significant injuries, we're talking severe shattering, comminution of that posterior wall, a penetrating injury, a large or persistent CSF leak, or evidence of actual frontal lobe brain damage.
Hmm.
A procedure called frontal sinus cranialization is often performed.
Cranialization? That sounds intense. What does that actually involve?
Think of it like this. The sinus cavity is essentially unroofed from behind. The entire posterior wall, the bone separating the sinus from the brain, is carefully and completely removed.
Wow, okay.
This effectively makes the former sinus space continuous with the anterior cranial fossa, the space where the front part of the brain sits. It eliminates that dangerous dead space right next to the brain. A absolutely critical step here is the meticulous removal of all of the mucosal elements. Every tiny scrap of that mucus-producing lining must be stripped from the remaining sinus walls and any bone fragments used in reconstruction.
Why is that so important?
Because if any mucosa is left behind, it can potentially lead to the formation of those gallade mucosalis we talked about, expanding cysts that can cause major problems years later. So complete removal is paramount. The now open sinus, devoid of its posterior wall and lining, is then often packed, obliterated, usually with soft tissue like harvested fat, to eliminate the dead space. And finally, the anterior or front bone wall is carefully reassembled over the top.
Okay, that makes sense. You mentioned NFOT obstruction and sinus obliteration earlier. Are those distinct concepts, or are they sometimes used interchangeably?
That's a great question, and it's really important to distinguish them, though they often go hand in hand in treatment. NFOT obstruction specifically refers to plugging or blocking the outflow tract, that drainage pathway.
Sealing the drain.
Exactly. The goal here is usually to isolate the sinus cavity or even the brain cavity after cranialization from potential contamination coming up from the nose, preventing ascending infection.
Okay.
Sinus obliteration, on the other hand, refers to eliminating the entire dead space or air within the sinus cavity itself, usually after the mucosa has been removed.
Filling the space.
Right. Filling the space to prevent any future air or fluid collection, like blood or mucus, which could get infected or form a mucocele. So one is about blocking the drain, the other is about filling the entire sink, so to speak.
That's a helpful analogy. What materials do they use for this?
Various materials are used. For obstruction and obliteration, common options include tissue harvested from the patient's own body, like strips of temporal fascia or muscle from the side of the head, sometimes bone grafts, or various synthetic fillers and commercial tissue sealants. Historically, though, harvested fat, often taken quite discreetly from around the belly button using a small periumbilical incision, has provided very reliable and desirable results for obliteration. It fills the space well and integrates nicely.
It's incredible how much science and delicate reconstruction goes into these repairs, using the body's own materials where possible. What about more minimally invasive techniques? Are those playing a bigger role now?
Absolutely. There's been a strong drive, understandably, to minimize visible scars and surgical morbidity. This has led to a significant increase in the use of endoscopic techniques.
Using cameras through the nose.
Exactly. Using tiny cameras and specialized instruments inserted through the nasal passages, surgeons can now perform many tasks that previously required large external incisions. This is particularly useful for reducing and fixing certain types of anterior wall fractures, and especially for managing issues with the frontal sinus drainage system. The NFOT may be opening it up, or even performing limited mucosal removal endoscopically. It's really been a game changer for selected cases in terms of patient recovery and aesthetics.
That's great progress. Now, moving beyond the frontal sinus specifically, that NOE complex itself poses unique challenges, especially when we consider things like vision and the tear ducts. What happens when those structures are damaged?
You're absolutely right. The NOE region is incredibly complex functionally and aesthetically, and early surgical management is really important for NOE fractures. Because if these deformities, the splayed bones, the detached tendons aren't fixed properly and promptly, they lead to severe cosmetic issues, like the eyes appearing too far apart or the bridge of the nose looking flat. And these late deformities are notoriously difficult to correct satisfactorily later on.
So getting it right the first time is key.
Critically important. For the more complex fractures, those Markowitz type 2 or especially type 3 where that medial canthal tendon might be avulsed or attached to tiny fragments,
Uh-huh.
surgeons often need to use a technique called transnasal wiring.
Wiring across the nose.
Essentially, yes. It involves passing fine wires through the remaining stable bone on the inner side of the eye socket, potentially across the nasal septum, to capture that tendon-bearing fragment, or the tendon itself, and pull everything back medially towards the center and stabilize it.
Wow, that sounds delicate.
It is. And there's a key technical detail. The fixation where the wires are anchored or tightened needs to be directed slightly posterior and superior to the lacrimal fossa. That's the little dip where the tear sac sits.
Why that specific direction?
That posterior and superior pull helps to effectively decrease that widened intercanthal distance, bringing the eyes closer together, and it also helps prevent a secondary widening or flattening of the nasal bones, which can cause that blunted appearance. Surgeons often even aim for a slight overcorrection initially, pulling things just a tiny bit closer than normal, anticipating some minor relaxation over time.
So a subtle detail in the vector of the pull makes a huge difference in the final look and function. Amazing.
It really does.
But what if the tear drainage system itself, the lacrimal apparatus, is damaged in the injury or during the repair? That sounds like it could lead to constant irritation and watery eyes.
It definitely can. Damage to the lacrimal drainage system is a common complication and can lead to epiphora, which is that persistent excessive tearing. It's very symptomatic and can be quite bothersome for patients.
So how do they figure out if the drain is blocked?
Doctors use specific tests called Jones tests to assess if the tear duct is open and functioning properly. The basic Jones eye test involves simply putting a drop of fluorescent dye, fluorescein, into the eye and then checking inside the nose a few minutes later with a special light to see if the dye has drained through.
It's simple enough.
If no dye appears, it suggests a blockage. Then the Jones II test involves gently irrigating saline through the tear duct system to try and pinpoint where the blockage might be. Is it high up, low down, or complete obstruction?
Okay. And if the tests show a persistent blockage?
If the tearing, the epiphora, persists and is bothersome, then a surgical procedure called dacryocysteronostomy, or DCR for short, is performed. The goal of a DCR is to create an entirely new drainage pathway for the tears, bypassing the blockage.
A bypass for tears. How is a DCR typically done? Is it a big surgery?
Well, the traditional method is the open or external DCR.
Yeah.
This involves making a small incision on the side of the nose near the inner corner of the eye. The surgeon then removes a small piece of bone between the tear sac and the nasal cavity and creates a direct opening, a new fistula, between the two.
Okay.
Often tiny, flexible silicone tubes, called Crawford tubes, are threaded through the natural tear duct openings, the puncta in the eyelids, down through the new opening into the nose, and left in place for several months, typically 4 to 6 months, to act as a stent and keep the new pathway open while it heals.
I see. Are there less invasive options?
Yes, there is also an endonasal approach now. Using endoscopic instruments inserted through the nostril, surgeons can perform a conceptually similar procedure from inside the nose, creating that same opening between the tear sac and nasal cavity, but avoiding any external skin incision. With the endonasal DCR, the tubes, if used, are typically left in for a shorter period, maybe around a month or so.
Good to have options that avoid external scars. Okay, so the immediate surgery phase is over, the reconstructions are done, and the patient is recovering. What does the long-term journey look like? What kind of post-operative care is involved? And what are some of the lingering issues people might face down the road?
Post-operatively, especially after sinus surgery, simple measures can make a big difference. Things like regular saline nasal sprays are very helpful. They can reduce symptoms of rhinosinusitis, keep the nasal passages moist, and prevent uncomfortable crusting. Medications called mucolytics, like guaifenesin, the stuff in some cough syrups, might also be beneficial. They help thin mucus, which can be useful since the mucociliary apparatus, those tiny cilia, can be temporarily sluggish or damaged after trauma and surgery.
Okay, what about decongestants?
Decongestants, either oral or nasal sprays, can be considered for short-term use, maybe a few days, to help with congestion. But the topical nasal sprays especially need to be limited usually to no more than 3 days because of the risk of rebound potential, where congestion actually gets worse when you stop using them.
Right, that rebound effect. And antibiotics, you mentioned uncertainty before. Are they always needed after such complex facial surgery?
It's still an area where there's No universal consensus regarding the use of postoperative antibiotics for
Yeah.
all cases. It really remains a highly individualized decision.
Based on what factors?
It depends on things like the extent of the soft tissue injury, whether the wound was heavily contaminated at the time of injury, the presence or duration of a CSF leak, the complexity of the repair, and whether the patient has other associated injuries or medical conditions. For facial fractures generally, if antibiotics are used prophylactically, penicillin or a related drug is often the first choice. But the specific antibiotic and duration really depend on the clinical circumstances.
Okay, so very case by case. Now, this is where the long game truly comes into focus, I think. What are some of those significant long-term problems that patients might face, sometimes years, even decades, after the initial injury and repair?
You're right. The long-term picture is critical. Complications can indeed range from immediate or early neurologic problems, anything from a concussion to a severe traumatic brain injury associated with the initial impact to infectious complications. Meningitis is probably the most frequent serious infection seen, or sometimes abscesses developing within the frontal sinus or even the brain.
Still a risk even after repair.
It can be, especially if there were delays in treatment or residual issues. But the chronic problems are particularly significant, partly because they can appear many years after the injury, often as a delayed and unwelcome surprise. By far, the most common chronic complication related to the frontal sinus itself are those mucosales we've mentioned a few times.
Remind us again what exactly a mucococcal is and why it's such a delayed threat.
A mucocele is essentially an expanding, slow-growing cyst filled with mucus. It forms when some of that respiratory mucosal lining from the sinus gets trapped maybe in a fracture line, or maybe it wasn't completely removed during surgery like cranialization, and it just continues to secrete mucus.
And it just keeps growing.
Yes, slowly but relentlessly. The trapped mucus accumulates, the cyst expands, and this expansion can gradually erode the surrounding bone. It can push into the orbit, causing eye displacement or double vision, or it can erode the posterior table and press on the brain tissue, potentially causing serious neurologic problems.
And this can happen years later.
Absolutely. Mucosales have been reported developing as late as 20 years postoperatively. It's quite astonishing. And that's why routine long-term imaging follow-ups, often with CT or MRI scans, are so critical for patients who've had complex frontal sinus fractures, potentially for many, many years after their surgery.
Wow, 20 years. That's a long time to be vigilant. What other chronic issues can crop up?
Other potential chronic issues include persistent pain and headaches that sometimes don't have an obvious anatomical cause found on imaging. Also, cosmetic deformities, dents, asymmetries, contour irregularities might not even become fully apparent for months or even a year after the initial injury, as all the swelling finally resolves and the tissues settle into their final position.
Ah, so the final look might change over time.
It can, yes. And then there are the sensory issues, which can be surprisingly common and quite impactful. Anosmia, the complete loss of the sense of smell, occurs in up to 38% of patients with these high central midface fractures, likely due to damage to the olfactory nerves where they pass through the cribriform plate.
Nearly 40% lose their sense of smell. That's huge.
It is. And a related issue, a decreased sense of taste, or hypogesia, also affects a significant number, maybe around 23% of patients. These sensory losses can profoundly impact a person's enjoyment of food, awareness of environmental hazards like smoke or gas leaks, and overall quality of life.
Definitely things we take for granted. Can anything be done for those later cosmetic deformities that might emerge over time if someone isn't happy with the result a year later?
Yes, absolutely. Secondary correction of post-traumatic deformity is often planned and addressed, typically 6 months to a year after the initial surgery, once the tissues have fully healed and settled and the final contour is clear.
What does that involve?
Surgeons use a variety of materials for these secondary reconstructions to fill dents or rebuild contours. Options include bone grafts taken from the patient's own body, like from the skull, rib, or hip, or various biocompatible synthetic materials like titanium mesh, medical-grade polymeric silicone implants, or acrylic cements. And there's a really exciting development here is the advancement in computer design and technology.
CAD/CAM.
Exactly. CAD/CAM technology now allows for incredibly precise, computer-generated single-stage techniques. Surgeons can use the patient's CT scan data to digitally design a custom implant that perfectly matches the defect and mirrors the uninjured side. This custom prosthesis can then be 3D printed or milled from a material like PEEK or titanium.
So a truly personalized fit.
Precisely. It ensures the best possible aesthetic symmetry and functional outcome for these often challenging secondary corrections.
It's just incredible. From the microscopic silently beating cilia lining your sinuses, doing their cleanup job 250 times a minute, to the precise computer design reassembly of shattered bone fragments using custom implants. This deep dive has really revealed the stunning complexity and the absolute criticality of understanding and managing frontal sinus and NOE fractures. What stands out to you as maybe the most surprising or impactful insight from our discussion today?
What truly resonates with me is that delicate, almost unbelievable dance between the microanatomy and the macro consequences. It's fascinating and humbling how something as subtle as the natural variability of a tiny drainage duct between individuals, or the insidious, slow growth of a few trapped mucus-secreting cells over decades, how these tiny details can dictate the entire course of a patient's recovery and their long-term health and well-being. It really highlights this remarkable intersection of intricate human biology, the need for incredibly advanced surgical precision, and also the absolute necessity for ongoing long-term vigilance to manage these seemingly localized yet potentially profoundly impactful injuries. The whole journey, from the moment of trauma to hopefully full recovery, is just a testament to both the resilience of the human body and the relentless progress we're making in medical science and technology.
Yeah, absolutely. And for you, our listener, perhaps this serves as a powerful reminder of how the smallest, most overlooked details within our own bodies, those hidden processes like mucus clearance, those intricate structures like the medial canthal tendon, can have the most profound and sometimes unexpectedly delayed consequences when things go wrong. It really encourages us, I think, to consider how every single one of those micro-level anatomical details and physiological processes isn't just trivia. It actually guides critical, life-altering decisions in diagnosing injuries, planning complex surgeries, and ultimately in preventing future devastating complications. It shows us it's not just about fixing a broken bone, it's truly about understanding the body's secret language to restore not just structure, but function, appearance, and ultimately a life. Thank you so much for joining us on this deep dive into the often invisible yet incredibly impactful world of complex facial trauma.